disease. You can damage the brain, you can damage the intestine also. And also you have to keep the barotrauma also in the picture, because, and for that, we limit the pressure around preterm babies, VLBW babies, maximum 25. If it is going more than 25, we usually try to shift to the HFO. And term baby, we limit the PIP to the 30 millimeter of mercury. And when it is crossing 30, we try to shift to the HFO. So this is very important. All these things we understand that the ventilation should be safe. This is the concept of open lung ventilation. If you have collapsed alveoli, what happens? First of all, it doesn't take part in your ventilation, and it, because the repeated collapsing and opening, that causes strain and stress in the alveoli, and that causes inflammation, and that is responsible for the lung damage. So alveoli should be well open and your perfusion should be good. Then only your ventilation should be proper and gas exchange should be really the proper. Then coming to comfort, ventilation should be comfortable. Comfortable means you have to support all the breaths that is there, because if you are not supporting all the breaths, baby will not be comfortable. So it may ventilate with assist control, or you may ventilate with a SIMB and PSB, or you may ventilate with the if you are weaning to the with the PSB, and synchronize all the breaths. And also you have to use the proximal flow sensor. I will come this thing to the later on. So I usually ventilate in my unit with SIMB PSV with volume limit, and it addresses all the issues. It causes comfort to the baby. It is synchronized. It is all breaths are supported, and also it prevents the volume trauma. And many units will ventilate with the assist control with volume limit. So usually these two are being practiced nowadays. SIMB PSV with volume limit, or assist control with the volume limit. Coming to how does the ventilator works? Ventilator works by increasing the pressure in the circuit. So fresh gas is coming, air and oxygen is under pressure, a pressurized gas. And here is a valve, and this keep on opening, closing, and this will create a baseline pressure will be there, that we call is PEEP, and there will be intermittently pressure will increase in the circuit, that is PIP. So this is the graph, and they are the 6 parameters with they are the 5 parameters which affects the pressure waveform in the ventilator, and 6 knob is F5 knobs are like a flow. Flow will affect the how fast this pressure is achieved. So you can decrease or increase the flow. If you increase the flow, it will become a square one, and if you decrease the flow too much, it will become almost sinusoidal. Then it will become V-shaped like this. And there is a TI. TI means how much inspiratory time we are giving. So how much time the increased pressure is there. Then you have PEEP, how much pressure maximum we are giving. And rate also. There are so 6 knobs you have to operate. And how do you operate this? How do they affect the ventilation? PEEP it affects the FRC and it affects the oxygenation. PIP affects the tidal volume. Rate, it will affect the minute ventilation. TI will it will affect the map, and also it will affect the oxygenation. Is easy to understand, FiO2. And flow waveform. If you have a high flow, it will become a square wave, more map. A low flow, it will become a triangular one. Triangular one will have less maps. So flow also affects. This is the last thing we interfere with. Usually we play around with PIP, PEEP, rate, TI, and FiO2. So what are the modes of ventilation available with us? Before going to the modes, we have to realize how does this waveform is made. So there is a constant pressure in the tube, that is PEEP. There is increase. There is a start of the breath, that is called trigger mechanism. How the breath is being triggered. Then B, if pressure is increasing, how it is pressure is being limited, that is limit. Then when the pressure starts coming down, that is cycling. How is it being cycled? So the trigger mechanism can be flow triggered. That means if baby is started inspiring, then the flow will get reversed. The breath will trigger. It may be pressure triggered. If a baby starts breathing in, there is a drop in the circuit and the breath will trigger. Limit means you can put a limit like a PIP. It should not go more than 25. Or limit can be volume. If 5 ml volume is delivered, it will stop ventilating the baby. Okay, cycling mechanism means when breath will end. So if you have given in conventional ventilation, what we do? TI, inspiratory time. Once that TI is over, that time is over, the ventilator will stop giving the PIP. It will come down to PEEP. And there is also cycling mechanism like PSV. It depends upon the flow. And when the flow in the circuit is coming down, that when the ventilator will realize that there is no need of inspiration and it will get cycled. It will stop giving the breaths. That is called flow cycled. So it can be limited. It can be pressure limited ventilation. It can be volume limited ventilation. Cycled means we have time. So time, inspiratory time cycled, or it may be flow cycled. When the flow is coming down in the ventilator circuit, that is called flow cycle, that is PSV. So there are two control modes of ventilation, pressure control and volume control. And in neonates, usually we ventilate with the pressure control ventilator. And there are few people will still ventilate with volume control, but it has got problem in the neonates because it will have variable PI. Also, like if you see the flow pattern, it causes a lot of asynchrony because of fixed flow in the volume control ventilation. So in the neonates, we ventilate with the pressure control ventilator, and it is better than the volume control in the theoretically in the newborn babies. What are the modes available with us? We have IMV. IMV is intermittent mandatory ventilation. Just see these are the breaths given by the ventilator. These are the spontaneous breaths. So it doesn't synchronize with the baby. So you can see here, ventilator is giving the breaths, but baby is trying to expire. So there will be a lot of asynchrony. So IMV should not be used nowadays. It creates a lot of asynchrony. Asynchrony means you have barotrauma, lung will rupture, IVH will happen. Okay. And this is the SIMV. SIMV means like baby is here breathing. There are 1, 2, 3, 4, 5, 6. 6 breaths are there, but only 3 breaths are being supported by the ventilator. So it depends upon the number of breaths we set. If you have baby is breathing at the rate of 60, and if you have set the rate is 30, then only 30 breaths will be synchronized with the baby's breath. You can see here, all breaths are synchronized. Okay. Assist control, PTV, SIPPV, all are same. This will happen. What will happen? It will support all the breaths. Okay, it will support all the breaths. What is SIMB with PSV? SIMB with PSV is like if you have 1, 2, 3, 4, 5, 6, 7 breaths, and out of this only 3 are SIMB breaths. what the rate we have set, but other 4 are pressure supported. This again, if you have, like usually we give pressure around 75 to 80% of the PIP usually. PSB is around 75 to 80% of the PIP. So all other breaths also will be supported. So baby will be comfortable. So what is the problem with the pressure limited ventilation? If you have rapidly changing compliance, like here the yellow one, baby was here RDS. You have fixed pressure, PIP is fixed, and you have given surfactant. What will happen? Compliance will improve and your tidal volume will keep on increasing. So from here, same pressure, your tidal volume will say around, it was 4 ml. After some time, it will go to 8 ml, and after that, it will go to the 12 ml. So that will cause volume trauma. But if you have volume controlled or volume limited rather, volume limited, you have put a limit in the ventilator. So ventilator should not give more than 8 ml. It should not give more than 8 ml. So what will happen? Your pressure, set pressure is here, but since ventilator is limiting the volume, your PIP will automatically start coming down. So PIP was say here, say 25, we have given surfactant, compliance has improved, and there is a volume limit. So PIP, delivered PIP will come down from 25 to 20 to 16. So volume limit. So this is a hybrid mode of ventilation. So it is a pressure controlled, volume limited ventilation. So in this what happened, we fix a PIP max. It's like a term baby, usually we fix at 30, and preterm baby we fix around 25. Okay, and the delivered PIP will depend upon the volume, how much has been delivered. See here, volume target is this much. If you say like say 10 ml, this volume delivered is lesser than that. So ventilator will sense this and it will increase the pressure. I'll say other times say volume delivered is more. So then say 10 ml target was there, now it is delivering 15 ml. So ventilator will sense this and it will decrease the PIP. So PIP will vary, but there will be a fixed maximum PIP. So this is called pressure control volume limited ventilation. And nowadays, most of us, we are ventilating with pressure control volume limited ventilation. What are the advantages? Advantage is that less hypercarbia and hypocarbia, less lung damage, less risk of lung de-recruitment, less work of breathing, and automatic weaning of PIP. If compliance improve, PIP will automatically come down. There are many modes. I will not go into detail. I will just skip this. So how do we measure this flow? This is very important because tidal volume is very small. Like say if we have 600 gram baby, tidal volume will be almost 4 ml, 3.5 to 4 ml. And we use cuff tube, uncuffed tube also. So there will leak also. And there will condensation, dirt and flow sensor also will get damaged. And condensation circuit also will cause auto triggering. So many things are there. So you have to know about the flow sensor, how does it work, and which flow sensor should be used. This thing, flow sensor should be at the patient end. Why? Because if you see here, this baby is not attached to a flow sensor, proximal one. So what will happen? Flow sensor is here in the ventilator. So if ventilator is giving the pressure, it is increasing the volume in the lung. Apart from that, it is causing expansion in the circuit also. Expansion in the circuit along with so ventilator will measure both. You increase in the tidal volume into the lung as well as it will measure the expansion of the circuit also. And we use nowadays the disposable circuit. There's very compliant circuit. So the tidal volume measured here will be much more than what is the real tidal volume. So you should never, and also it will be not very sensitive to pick the small changes if you have flow sensor here in the ventilator. So you should never use distal flow sensor which is inside the ventilator expiratory valve. You should never use it. You have to have a flow sensor here. Okay. These are flow sensor here. There are many different types of flow sensors are there. There are flow sensor and few of the ventilators, they give proximal pressure sensor also. And that is the benefit of that is if your flow sensor is not working, it can synchronize with the pressures like SLE ventilators, Leone ventilators, they have dual sensing. They have a flow sensing also, there are pressure sensing also. So you have dual sensing, that is safeguard. If your flow sensor is not working, it will sense for the pressure. But you have to remember that your flow sensor should be working. If flow sensor is not working, the ventilator is giving IMV, intermittent mandatory ventilation. Okay, and whatever we have learned, synchronization, volume, all this will be all rubbish. Okay, so you have to make sure that your flow sensor is working. That is crux. And if flow sensor is not working, whatever we have learned, whatever we are learning in the textbook, whatever workshop you are attending, all are useless. So you have to keep the flow sensor working. So coming to the disease-specific ventilation, there are three types of basic pathologies are there. One is stiff lung pathology. Stiff lung, the classical is RDS, where the lung is not compliant, RDS and pneumonia. So where we have target volume is 4 to 6 ml per kg. PIP usually you start with 16 to 20 depending on the lung disease. If you have a whiteout lung, I will start with 20. If not that, like only the reticulogram pattern is there, then I will start with 16. So you start with 16 to 20, then titrate. And I told you that maximum PIP in VLBW babies, we target around 25 and term babies less than 30. PEEP around 6, we start and 6, 7, 8, we can go up to 8. If you have hyper expansion, then sometimes we come down to 5. Rate is 40 to 60 and TI is low because lung is compliant, lung is stiff. So you have low TI, usually 0.3 to 0.35. Then other extreme is the trapped lung. There is obstruction, there is a hyperinflation in the lung. That is meconium aspiration syndrome, typical meconium aspiration syndrome. In this PIP, higher PIP is needed and PWP around 5 we keep. Sometimes even 4 also we keep sometimes. Usually we start with 5 and PIP, higher PIP is needed. Here you need longer TI and low rate. Low rate, longer TI. Rate may be say 30 to 40 and TI 0.4 to 0.5 seconds. There is third one is fragile lung. Lung is not developed properly. And if you ventilate, if you try to ventilate aggressively, they will rupture and it will cause lung damage. So the typical is your CDH and lung hypoplasia. Okay, and these required expert intervention because you have to set the say PIP less. I mean, term babies we know will not go more than 25, and we accept smaller tidal volume. We accept permissive hypercapnia. So that like CDH or pulmonary hypoplasia, we try to ventilate with the low tidal volume, higher rate. Okay, and slightly more FiO2 we give, so the lung damage should not happen. PPHN is other thing. We have to optimize the lung and recruit the lung, then it will work. And whatever you give like nitric oxide and all, it will work only if you recruit the lung. Apnea and post-operative care, you have to give minimum support. Tidal rate around 15 to 25, not more than that. This is a common mistake done. Like babies with HIE, ventilate and rate is set at 60 and FiO2 requirement is 21, pressure is just 14/5. That should not be there. Okay. If your lung is normal, FiO2 is minimal requirement, and you are ventilating with the apnea, like apnea of prematurity, maybe HIE, your ventilator rate should be 15 to 25, not more than 25. So how do you monitor the baby? You monitor the clinically with rise in chest rise, work of breathing, then you monitor perfusion by CRT, heart rates, your scale rate also, a bit sounds, technical pulse oximetry, and if you have PPHN, you monitor both pre and post ductal. If you have facility to do capnography, it's better, but then you do blood gases. The acceptable target zones are like SpO2 90 to 95, PaO2 50 to 80, PCO2 45 to 55. Sometimes we go up to 55, even sometimes to 65 also if pH is more than 7. But this is for the chronic ventilation, not the acute ventilation. Usually we target around 40 to 45. Okay. And pH around more should be target should be more than 7.25. If you're going to less than 7.2, we get worried. Hypocapnia, hypocarbia, I have explained. And how do we assess the expansion of the lung? By the ribs. So 7 to 9 ribs, or maybe if you are difficult to ventilate, maybe 8 to 9 ribs is okay. Then you should never forget humidity. This many times it happens in the rounds. Baby is deteriorating. If you go and see, the humidifier is off, or sometimes there is no water in the humidified chamber. That should not be there. Like there are studies have shown that if you don't provide proper humidity for 30 minutes, your work of breathing increases by twice. Okay. So if you don't give humidity, what will happen? Mucus will get thickened, then cilia will stop working, and after that will have lung cell damage. So humidity humidity should be very good. And if you have proper humidity, your lung damage will not be there, your tube block will not be there, secretions will be not thick, so pneumonia will be lesser. So you have to give a proper attention to the humidity. Okay. And sometimes what happens is babies are agitated, and just we give sedation, increase the sedation, increase the sedation. But it should not be like this. We are monitoring the baby. If baby is agitated, you have to see why this baby is agitated. That is important. Tube is displaced, like tube is touching the carina. Tube is up, like it is at the glottis, around the vocal cord. Then babies will be disturbed. Tube is getting blocked. Pneumothorax has happened. Ventilator is not working properly. Then check the gas. Underlying disease is worsening. Hypoxia is happening. That's why baby is irritated. Hypercapnia is the baby is irritated. Or ventilation, synchronous ventilator, flow sensor has stopped working. The synchronizer is not there. So before increasing the sedation or starting sedation, if baby is fighting the ventilator, you have to address all these issues. Many times I have seen just they increase the, say, babies on fentanyl, they will increase the fentanyl, or Dexit, they will increase the Dexit. So that should not happen. Why the baby is in trouble, that we have to address. So how do you address the acute deterioration? We all know dope. It can be tubing displaced, obstructed, pneumothorax, or equipment failure. Then again, S also dope. If you expand it, then it dopes. Then there is stomach or splinting of the chest. There is splinting, or maybe the stomach is dilated, that is causing the problem. So if you have baby is deteriorating on the acute deterioration, first reflex should be disconnect. Take the baby on ambu bag. That should be the first action. Then you see what will happen if you have ventilation is easy. And if on ambu bag is the equipment failure or circuit leak or incorrect ventilator setting. Okay. If you are kept on ambu bag and it's hard to ventilate, or air entry is only one side, then it can maybe tube is obstructed, tube is displaced, or pneumothorax is there. Okay. Then you address the issue, what is the main problem, then you accordingly you solve the problem. So if you have like babies with desaturating, slowly it has gone up, then you see, but what is happening, secretions are there, PPHN is there, pneumothorax is there, or maybe you will increase the pressure, okay? If you have RDS is bad, then it gives surfactant. Ventilation, if hypercarbia, hypocapnia is happening again. If hypercarbia is there, the first thing the resident will do, it will increase the pressure. They will not check for the obstruction, what is happening, or leak is there or not. So you have to check why CO2 is rising, okay, before you increase the pressure. Weaning is sequential weaning is there. You have to first priority is wean the FiO2. FiO2 should bring down to 0.3 to 0.4. Then priority is what is driving the CO2. If you are ventilating with the PIP, the pressure control, the PIP should bring down the PIP. And if you have like ventilating with the volume limit, you may have to make it come down on volume also. Then last one is PEP, PWP. Last thing which start decreasing is the PWP. Okay. So first we win the FiO2, then your pressures, PIP or tidal volume, it is more. Then you start decreasing the PWP. Okay. And when do you extubate the baby? If you have come down to map around 7, 8, PWP is 5, PIP is around 16, rate is around 15, 20, FiO2 less than 30. Okay. You have to see that pH should be okay, your CO2 should be okay, and patient should be hemodynamically stable. That is there. Patient should have good spontaneous respiratory effort, hemodynamically stable, and for which you have intubated the baby, that basic pathology should be improving. And a preterm baby, VLPW baby less than 32 weeks and up, you have to see whether caffeine has been given or not. And you should not put the baby on nasal oxygen. You have to keep the baby on, say, CPAP or NIPPB. If you have a bigger baby, may extubate to the high flow. So the final message will be like a ventilator does two jobs, oxygenation and ventilation. You have to differentiate which one will affect the oxygenation and which will affect the ventilation. Okay. And try to fix that. Open the lung and keep it open. This is very important. And over the years, we have learned this. Now we are PWP, what we give is much more than what we are practicing 20, 25 years back. So minimum we start with 6 and sometimes we go to 7, 8 also. Volume is injurious to the lung. Okay. Not pressure that much. Okay. So target should be 4 to 6 ml. Should never give more than 7 ml per kg in acute ventilation. Okay. And chronic ventilation, sometimes we go to 7, 8, 9 ml also, like CLD babies. But for the acute ventilation, should not go cross more than 7. So 4 to 6 is the target usually. Be permissive. If your pH is all right, more than 7.2 or 7.25, and to accept CO2, higher CO2, especially in the chronically ventilated babies. And most important, non-invasive ventilation is to master. Try to maximize the use of non-invasive ventilation. And if you have to intubate, try to extubate as early as possible. That is there. Okay. Thank you. Thank you very much. Okay. Thank you.
Yeah, thank you, Dr. Rajesh, for covering the important and every aspect of basic ventilation, I can say. So thank you all. And participants, if you are having questions, so that can be taken. It's a very important message. Okay, you should optimally use non-invasive ventilation and invasive ventilation only once it is really required. And you should have a strategy to extubate as early as possible. Okay? Don't allow just for comfort that patient is on ventilator and then, okay, so you don't wait. Hyperoxias and ventilation inherently has a chances of getting lot of complications. So try to extubate from invasive ventilation as early as possible. So,
So there is a question, sir. There are three questions. First is, what is your take on regular sedation for babies on ventilation and also on use of muscle relaxant? Your experience.
Muscle relaxant, absolutely no, no, and no. Very, very rarely. I don't have. I have given relaxation to anybody till now. Okay. So and sedation also, like when we were again PGs, everybody was on morphine that time. Nowadays, this is not a routine. So if baby is not comfortable, then we give uh, sedation. And nowadays, if you have difficult to ventilation like MS, PPHN, diaphragmatic hernias, okay, then we give sedation. And sedation of choice should be that fentanyl should be the, for morphine used to be the first line, but nowadays surveillance shifted to fentanyl. And but nowadays we are a lot of babies are on dexmedetomidine, that is Dexit, and uh, we have started using for last 3-4 years dexmedetomidine, and it's quite well and less sedation and very good analgesia. Okay. So that is there, but routine sedation is not there.
Do you use dexmedetomidine and also in preterm babies?
We have started using it, and not much of problem.
Second question is, which mode is better, assist control or SIV? What is the advantage?
So I told you that as if you are using SIMB, you have to put the PSB also. So SIMB with PSB, not plain SIMB. And because the if you use plain SIMB, the many breaths will not be supported. The baby may feel discomfort because breathing through the small endotracheal tube is difficult. So if you are using SIMB with PSB, assist control problem is like theoretically it looks better, but the problem is auto triggering. Many times we feel auto triggering. There's a, if you have for any reason, like you have set the trigger very low or with the conditions in the tube, and it will cause. If you take care of auto triggering, well, then assist control should be the choice. Otherwise, SIMB with pressure support. Alone SIMB, okay, nowadays people don't use it. I will also not advocate for that.
How to manage condensation in the ventilator tubings?
This is the perpetual problem. And first thing, like you try to acquire a good quality humidifier. That is one thing I have learned over the years. And second thing is your temperature in an ICU should not be very low, because condition happens because of difference in temperature in the tube and difference in the environmental temperature. So if you are at an ICU temperature is say we are keeping 20, 22 and all, a lot of conditions will happen because nobody keeps, but sometimes by mistake you can have these problems. And so other thing is like the few ventilators, like you have Sophie, they supply cloth sleeve. So that the basic idea is the temperature difference between the room and the your inside circuit. It should not be too much. So practically what you do, like you have a gauge piece, we just wrap the gauge piece on the tubings, 2 layers of gauge piece. That many times it does help. Then other thing is nowadays in the ventilator tubings, they are now circuits are like embedded circuits have come up in the market. Embedded circuit means your heater wire will be in the wall and it will not be in the lumen, your heater wire. And what we have seen, embedded circuits have less condensation than the inside wall, inside lumen. And also like if we have dual heated circuit means expiratory limb is also being heated. There also the conduction is very less. So if you have dual heated embedded circuit, good humidifier, and room temperature is very good, actually 26, 27 like that, condensation will not be a problem. But other things are what I have told you, room is cold, your humidifier is not very good, you are using circuit is not good, then you compromise on the circuit, then condensation will be there.
What is PSV percentage in SIV plus PSV in SOFI ventilator?
So it depends upon your traditionally we PSV 75 to 80% or PIP, what you told. Like if you have 16 PIP, then around PSV will be around 13, 14. Okay. So definitely 75 to 80% we keep the PSV percentage. So on all ventilators, you can manipulate it. Okay. It's not fixed for the ventilator. You have to manipulate it. Okay.
Uh, Next question is regarding opioid withdrawal symptoms. If we use fentanyl for 3 days in a baby with PPHN,
Mhm.
have you experienced anything like opioid withdrawal symptoms? Your experience?
Not much. Because usually what happens nowadays, PPHN, with the advent of your surfactant and nitric oxide and all, PPHN management has become much easier. And we need not give sedation for quite a long time. So rarely, sometimes we have to, PPHN does create problem. Recently, we had a baby, black lung PPHN who was on, say, nitric for almost 7 days. Okay, say nitric, sildenafil, milrinone, everything. So in that, sedation is slowly withdraw sedation, and sedation withdrawal, I don't know, we have not encountered that much.
Uh, your take on remifentanil, sir, versus fentanyl?
Remifentanil I have not used, so practically I don't have any experience. So what I have used, dexmetadine, morphine, and fentanyl. Morphine getting is a problem. Procurement of morphine is a problem, but morphine is very good drug. But fentanyl is a little better than the morphine. And dexmedetomidine is a safer drug. If you don't need that deep sedation, your dexmedetomidine should be the first choice nowadays.
Anybody has any other questions? They can put in the chat box or unmute and ask directly.
So my message should be like flow sensor should be working. That thing, one thing is that I have seen many a times the flow sensor is not working. So flow sensor should be working properly. Your humidifier should be working properly. If your flow sensor is working properly, humidifier is working properly, your basic ventilation will not be that much problem. These two things if you address. And unnecessary, you don't give a lot of volume. If you start measuring the volume, okay, babies will be all right.
Good evening to you, sir. Very crisp presentation. The role of extubation steroids, sir, it is still on, sir? 3 or 4 doses, especially after 4 or 5 days of ventilation.
Up to 7 days, we never give it.
Okay.
Okay, up to 7 days, we never give it. If you have a prolonged 10 to 14 days, then sometimes we give it. But routine is not a routine nowadays. If you have extubation failure 2, 3 times, then again we try to give it. Okay, if you have extubation failure, okay. But routinely till 7 days, no. No to extubate.
Short ventilation. Thank you.
No. Till 7 days, no.
Thank you. Thank you.
I think, sir, books for neonatal ventilation.
Goldsmith.
Goldsmith is the Bible, yeah, definitely.
Goldsmith is the Bible, and there is no replacement for that. And there is one written by Satyan. That is also a quite good one. Good illustrations are there. Okay. I think these two are recommended.
I have a chance to meet Dr. Rajesh. If you remember, there was a workshop at Nagpur on high frequency ventilation. So Goldsmith was the facilitator.
Mhm.
So it was, I think, in 2005 or so. Yeah.
Mhm.
So I think 20 people they have invited. Dr. Satish Dev Pujari, he has organized.
Mhm.
So I met first time. Dr. Susman Angia was there, Ramesh,
Ah.
Rams, and so 3-4 people from this side.
Mhm.
So,
It
so
was.
it, and it was a live demonstration on lung peg,
Mhm.
high frequency ventilation. So yeah, it's a really Goldsmith ventilation unit.
Goldsmith, there is no alternative to Goldsmith. Okay.
Any take home message from yourselves, Essence sir, before we.
Yeah, so very nicely, I think he touched every aspect, important aspects, and flow sensor is really highlighting very important part, and humidification is really. So if anyone is ventilating and not taking care of these humidification and sensor, so I think they are creating more problem rather than helping. Yeah. So just like everything happened, discuss about humidification and all. So condensation. So condensation basically happens once the gas or air flows from hot to cold. So some condensation you may expect in expiratory limb at times, but there should not be any condensation in inspiratory limb. I think it's still a dual condensation. This is not available widely now.
No, cost has come down nowadays.
Yeah,
Available from Fisher and Paykel and other companies also.
yeah,
Cost has come down to almost 2,500 roughly.
yeah. And
2,000.
another strategy is like room temperature definitely, and inspirate this limb tubings may be under warmers if you are facing much problem. And expiratory limbs should not be like it should be dependent.
Yeah,
So that condensed part should not go back. So these are the few tips, and very nicely I think you highlighted the every aspects, important aspects.
Thank you, Rajesh sir, for making this complex topic so simple and covering went through. Thank you, Essence sir, for moderating and all the participants. There are about 100 participants who had joined, and we look forward to the next session. Thank you so much, sir, Rajesh sir and Essence sir.
okay. Thank you, Akash. Thank you.
Excellent session, Rajesh.
Oh, thank you, sir. Thank you. It was very difficult to condense in 45 to 50 minutes, but
Yeah.
try to condense it.
Sir, yeah, how you take the TPs used by residents for the resuscitation, just out of curiosity, because things I don't know why, what the people hesitancy is there. No, this is not in context with the ventilation as such.
And TP is like change is always not difficult. So that is the only thing. You keep on hammering. Use it, use. Or just remove bamboo back from there.
That's the thing.
Very difficult. Very difficult. I don't know why the confidence is not there in the team residents that it will.
That's why. So easier one is to like whenever you try to use TPs in the NICUs first, whenever child is deteriorating. So then the resident will get confidence.